Good morning, everyone. So I'm honored to present to you to our topic on glucose to lymphocyte ratio as a prognostic marker for cholangiocarcinoma. So a little bit of background. So cholangiocarcinoma, or CCA, or cancer of the bile ducts, is a cancer with only a 5-year survival rate of only 24.6%, which is a very low percentage, and its incidence is highest in Thailand worldwide. So specifically in the Northeast, and yet there is no definite prognostic marker for this disease. So this begs the question: could a routine blood test predict a prognosis? And other studies have shown that uh, high glucose enhances CCA progression, uh, and low lymphocyte was associated with poor prognosis. So this brings us using the glucose to lymphocyte ratio to light. So because and so our aim was to analyze the survival and correlate GLR with other clinical parameters. So uh, our our data was collected by the Cholangiocarcinoma Research Institute of Thailand at Khon Kaen University, and all subjects were patients that were available during the years 1998 through 2000, and subjects that met the inclusion criteria, which were patients with histopathological confirmation of cholangiocarcinoma and ages above 18 and resected cholangiocarcinoma, and all have complete fasting blood glucose and lymphocyte records. And excluded subjects were patients without histopathological confirmation of cholangiocarcinoma, and that brought us to 85 cases. So we think that high glucose to lymphocyte ratio is associated with poor prognosis, but so we had to define which glucose, what value of glucose lymphocyte to ratio what is high. So we did ROC and Jordan's analysis, and we had the cutoff point at 0.0417, and so our demographic data. So our patients most were above the age of 56, which is the median age for cholangiocarcinoma, and most were male. And we also have the baseline characteristics for other clinical parameters that we were going to analyze. So we did a Kaplan-Meier analysis, and it showed that the patients with the high GOR, or patients with the green line, had significantly lower survival. And we also did a Cox proportional hazards regression analysis, and patients with high GOR had a significant hazard ratio of 12.582, and we also did a univariate and multivariate analysis, and it showed that high GOR was associated with the male gender and male sex, and also associated with a survival time of less than 6 months. We also did a Spearman role correlation, which showed that GOR was significantly associated with survival time, globulin, total protein, and lymphocytes. All of those were negatively correlated, and high GOR also had lower globulin compared to low GOR from our students' t-test. So our statistical highlight is that high GOR was associated with shorter survival, and it showed negative correlation with globulin and total protein as well, and more high GOR was more associated in the male sex. So our acknowledgement, this work was supported by the Dr. Pasatong Research Fund of the Medical Association of Thailand. Thank you.
It was such impressive work. Any doubt All queries?
Thank you very much for your presentation. I have a question. I'm wondering how you might explain the high GLR that is associated with like the use of like the marker, because the high GLR means like a high blood pressure or low lymphocyte.
High GLR is high glucose with a
No,
low
no,
lymphocyte.
sorry, blood sugar, high glucose or low lymphocyte. So how?
So it can be both. Like a high GLR can mean the patient has high glucose or the patient has low lymphocytes or both.
And low lymphocyte means the patient is weak, and so this could be the marker, or high blood sugar means like they are diabetes. Or...
Because high blood sugar was associated with like enhanced CCA progression, and low lymphocyte is also associated with poor prognosis of cholangiocarcinoma. So we thought of using the two ratios to, predict the prognosis.
Thank you for presentation. I have one question. How did you select the laboratory marker such as the glucose lymphocyte ratio, liver function test in this study? So usually the cholangiocarcinoma has the several blood tests.
Yes.
So do you choose it at the diagnosis, or how to choose it?
All of the lab data was collected pre-operatively because all of those subjects were underwent resection. So all of the lab data was pre-operative lab.
And this blood test was done before the treatment. Is that correct?
The
chemotherapy. So I'm not sure whether cholangiocarcinoma of the treatments include the surgery and chemotherapy.
Not chemo.
Not
only
right.
Only
Okay.
surgery.
Surgery.
Thank you for your in-depth knowledge.